Hello, and welcome to another chapter of Pediatric Primary Care. Today we'll be discussing Chapter 4 Justice, Equity, Inclusion, and Diversity. Justice, equity, inclusion, and diversity are foundational pillars that a just and equitable healthcare system must strive to achieve. Unfortunately, health disparities, health inequity, and institutional racism often plague the healthcare system. While many healthcare professional organizations issued a call to action in the elimination of race-based medicine and actively address health disparities and inequity, there is still much to be done. Adherence to principles of social justice, such as access to resources, equity, participation, diversity, and human rights is the primary method to reduce disparities and inequities that lead to poor health outcomes. It is important to address these issues as primary care providers, as there is significant evidence that racism and discrimination are substantive contributors to health inequities and disparities. Inequity, inequality, and lack of respect for diversity contribute to social determinants of health that are significant upstream issues, which influence and exacerbate underlying health states. Much of the chronic pathologic providers see on a daily basis in patients is preventable when equity and the social determinants of health are addressed. Healthcare systems should be designed to provide care that respects and values the individual's belief while understanding that systems are stronger when multiple worldviews are present. This chapter begins with meaningful definitions of justice, equity, inclusion, and diversity, as language is important as it provides insight into understanding critical concepts. Justice in healthcare is the creation of a caring environment through innovation and directed policy that includes compassion to dismantle structures of inequity. Structural inequities create differential access to healthcare and result in disparate health outcomes for individuals from different socially defined groups. Equity in healthcare recognized that all pediatric patients, regardless of age, sex, race, sexual orientation, socioeconomic status, or another societal defined status, deserve equal access to health promoting and health restoring services and care. Equity to access does not negate the fact that some individuals may need more additional resources, such as access to early childhood interventional programs, subsidized health insurance premiums, improved nutritional programs, than others to overcome negative social determinants of health. Inclusivity in healthcare is different. In a nuanced way, it holds that all children and youth and their families should have systems developed that allow them to have a voice in healthcare decisions and access to the highest quality of pediatric healthcare. Diversity recognizes that each individual defines and experiences health through their own personal lens that is influenced by culture, religion, gender, sexual orientation, health education, and socioeconomic status, to name a few. PCPs must be aware of structural racism to be able to identify and advocate for patients and families who are adversely affected by its effects. When discussing race with the context of healthcare, it is important to reiterate that race is a social, not a biological construct. Racism is the power system that affords opportunity and attributes value based on the social interpretation of how one looks. Racism creates a systemic disadvantage for some groups. It is at the core of racial health disparities and was pervasive in the system that were developed generations ago. The insidious institutionalization of racism and inequities are ubiquitous and often invisible to those not affected. Structural racism occurs when societies develop systems that are reinforced through policy, such as housing, healthcare, employment, criminal justice, and education, to control, segregate, and/or discriminate and affect resource allocation. Structural racism is linked to disparities in birth outcomes, increased risk of chronic illness, and increased interaction with the justice system. The history of racism, therefore, in healthcare. Understanding the history of the U.S. healthcare system is important to understand its connection to racism and how that shapes individuals' trust or mistrust of healthcare providers, institutions, and organizations. Modern healthcare systems were developed after the Civil War, as medical schools defined the standards for health and healthcare delivery. At the time, only white males with financial means were admitted to medical schools. Similarly, nursing education was largely limited to white women who could afford nursing training and education. Before that time, most healing occurred in communities, largely provided by women who were known healers and midwives. The early hospital systems that were developed did not serve Black or Indigenous people of color, and racially integrated hospitals did not exist until the passage of the Hill-Burton Act in 1946. The founder of gynecology, Dr. James Marlin Sims, conducted experiments on freed and enslaved Black women to learn more about female anatomy and physiologic function. In addition, he sterilized them against their will and without anesthesia. During the same time, the eugenics movement institutionalized and sterilized individuals with disabilities, those who were poor, and Black and Native American individuals, many by departments of the federal government, such as the Indian Health Service. So here we're taking a quick picture of different versions of equality, where the assumption is that everyone benefits from the same support. This equal treatment is not necessarily equality. Equity. Everyone gets the support they need. This is the concept of affirmative action, thus producing equity. And finally, justice. All three can see the game without supports or accommodations because the causes of the inequity has been addressed. The systemic barrier has been removed. So there you see the comparison of equality, equity, and justice. And as always, if I'm going ever too quickly, please feel free to hit pause and review on your own time. Distrust in the medical and scientific systems runs deep in some BIPOC communities due to a long history of unethical investigations that used BIPOC subjects in ways that would be unlikely to pass human subjects review boards today. Conducted from 1932 to 1972 by the U.S. Public Health Service, the Tuskegee syphilis study involved monitoring Black Americans who had syphilis to establish the natural course of illness. Subjects were allowed to progress to tertiary syphilis even after treatment was readily available. An extensive of the Manhattan Project involved injecting 18 Black males with plutonium between 1945 and 1947 to determine how the radioactive isotope is excreted and metabolized in the human body, with the aim of determining the effects of plutonium exposure in causing illnesses, such as leukemia. All subjects had numerous tissue and blood samples taken, bone biopsies, and tooth extractions to measure how plutonium is deposited in various tissues. Unfortunately, mistreatment of BIPOC individuals in the healthcare setting continues. In the 1800s, scientists believed there were significant anatomic, physiologic, and functional differences between races, and these differences were often used to justify different social policies. Decades of research that attributes differences in health and disease states between races can now be understood to be largely influenced by economic, environmental, and healthcare access, differences between groups, and to a lesser extent, biological differences between groups. The American Academy of Pediatrics, in their Eliminating Race-Based Medicine statement, notes the importance of recognizing that differences in race-based clinical care is a direct result of structural and systemic inequities and disparities in marginalized populations, and as such, these should be removed from use. An example of this is the current clinical practice guideline listing race-based differences for spirometry in asthmatic youth should be removed in future recommendations, as differences between groups are not believed to be genetic, but rather due to differences in social determinants, such as crowded living conditions or poor air quality, that affect pulmonary function. So adverse childhood experience, or ACEs, such as emotional, physical, and sexual abuse, homelessness, divorce, parental drug use, family mental health concerns, and parental incarcerations have all shown to impact the lives of children well into their adulthood years. The original ACE study included mostly white adults, many of whom had attended college. Therefore, a new framework has been proposed to include ACEs and adverse communities events to include factors such as violence, poor housing, discrimination, and a lack of opportunity. ACEs, as well as community factors, have shown to disproportionately affect historically marginalized communities. The COVID-19 pandemic highlighted the effects of ACEs and community factors have on health disparities. Poor quality and often overcrowded, racial, segregated housing led to challenges and the inability to practice social distancing. In addition, racial and ethnic minority adults are more likely to be employed in places where they are considered essential workers, and therefore had less opportunity to work from home and social distance. Health equity. The U.S. Department of Health and Human Services defines health equity as achieving the highest level of health for everyone. Health equity must include societal efforts to mitigate the inequalities and injustices that contribute to inequality. HSS also defines racial and ethnic disparities as a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantages. So, our current state. The impact of racism, especially in healthcare, has been highlighted in recent years. The news media has brought much needed attention to systemic racism, both in and out of healthcare system, with the treatment or lack thereof provided to Black Americans and immigrants. Health indicators. Health indicators such as receiving preventative care and accessing primary and subspecialty care reveal disparities in care based on race and ethnicity, socioeconomic status, and geography. For instance, Hispanic, Black, and Asian youth were less likely to have received medical care in the past year compared to white youth. Black and Hispanic youth were more likely to have cost as a factor in not having a healthcare need met and were less likely to have access mental health care services in the past 12 months compared to a white peer. Mental health disparities. Racially and ethnically diverse children and adolescents have higher rates of mental health and behavioral disorders, yet access services less frequently for these disorders compared to their white peer. Black and Hispanic youth are less likely to be prescribed medication for mental health disorders and are less likely to be treated utilizing evidence-based care. Suboptimal care and lack of access to high-quality mental health services have led to poor outcomes among these children and adolescents. Infant mortality and premature births. The Center for Disease Control and Prevention data indicate infant mortality rates are twice as high in Black infants compared to white infants. Black and Hispanic infants are at a risk of receiving care at lower quality neonatal intensive care units and worse care within a NICU compared to white infants. One small qualitative study also found that Black and Latin mothers whose infants were in the NICU reported feeling disrespected and receiving disparaging treatment. Low socioeconomic status is not always a contributing factor to disproportionate rates of prematurity among Black infants, as Black women with high socioeconomic status also face higher rates of prematurity and low birth weight. Some studies suggest stress related to racism and discrimination as a potential factor for this disparity. Segregation in residential areas is also thought to lead to decreased access to prenatal care and increased exposure to environmental hazards, such as pollution, are also hypothesized to impact prematurity and low birth weight. Asthma. The CDC reports that the Native Americans, Alaska Natives, mainland Puerto Ricans, and Black children have higher rates of asthma compared to white children. One study also showed that Black children had statistically significant higher rates of emergency department visits for asthma compared to Hispanic or Latin and white youth. So, our future directions. Healthcare provider professional organizations are making strides to mitigate racism in healthcare. There's a call to eliminate race-based medicine, especially within clinical algorithms. For example, the American Academy of Pediatrics retired the clinical practice guidelines on urinary tract infections, which had included race as a decision-making factor, asserting that Black children were at a lower risk for a UTI. At the local level, pediatric providers must be willing to have conversations about the impact of racism on the young person experiencing racism and those who witness racism. Primary care providers must also be aware of their own biases, both conscious and unconscious, and that could potentially impact the care they provide. Pediatric practices should create welcoming environments where all patients are treated with dignity and respect. Incorporating health equity concepts into daily clinical practice is a crucial step in addressing organization and systemic inequities that contribute to health disparities among marginalized groups. Some other strategies to consider may include creating a medical home in which providers are sensitive to the impact of racism on children and families, educating staff to provide culturally sensitive care and provide appropriate linguistic services, assessing for social determinants of health that are linked to racism. For patients disclosing that they have experienced racism, assess for mental health concerns such as anxiety and post-traumatic stress. Incorporate positive approaches to youth development to identify strengths and protective factors. And finally, in early literacy efforts, ensuring stories include characters and other images that reflect diversity. Finally, additional resources. The National Association of Pediatric Nurse Practitioners Statements on Discrimination, the American Academic of Pediatricians, Racism and its Effects on Pediatric Health, Academic Pediatric Associations, the Anti-Racism and Equity Toolkit, and finally, American Association of Child and Adolescent Psychiatry, Anti-Racism Resource Library. As always, I will slowly go through our reference list, and you can always feel free to hit pause so you can look at them at your own time. As always, I thank you for listening, and I'll see you at the next chapter. Till then, take care